My name is Ellen Baca. I'm the Lehigh Valley Coordinator for the Epilepsy Foundation, Eastern Pennsylvania. Thank you, attendees, for coming this evening. What you can do is put any questions that you have during this presentation in the chat box below on your screen, and your questions will be gathered by me and answered by our presenter at the end of their presentation. This webinar is being recorded, so please make sure that you remain muted with your camera off. I don't know if you can turn it on, but we don't, since we're recording it, we don't want that. So this webinar will be uploaded to our Epilepsy Foundation Eastern PA YouTube channel. Our speaker, Nicole Stawicki, is a registered dietitian at the Northeast Regional Center Epilepsy Group, which has a number of offices throughout New Jersey and New York. She's 15 years experience as a registered dietitian that focuses on nutrition therapy for epilepsy. Tonight, Nicole will explore diverse and effective dietary methods that have demonstrated potential in the management and reduction of seizures. So thank you, Nicole, for joining us this evening. And I am going to, if you're there, I'm going to hand it off to you.
Yes, I'm here. Can you hear me, Ellen, just before you mute yourself again?
Yes.
Okay, perfect.
I don't see you. I don't know if that's intentional or not.
Yeah, no, I just have my camera off for now because my dog keeps coming in, so we're just gonna have that off for now.
Okay.
Thank you so much, everybody, for joining me tonight. And like Ellen said, I am happy to answer or try to answer any questions that you have after the presentation. And then just so you're aware, I can't answer any questions about like specific like if your own specific case. I can really give general information, but I'm happy to answer as many questions as I possibly can. So tonight I am discussing optimizing wellness, dietary strategies for epilepsy. Okay, so like Ellen had said, just reiterate quickly, I've been a dietitian for 15 years. I have mainly done mostly worked with adults, and I've done nutrition support, so ICU, critical care, epilepsy, general neurology. And I've been with the Northeast Regional Epilepsy Group mostly since 2018 with like a brief hiatus in there. And then also right now I am working in pediatric neurology, adult oncology, and I also do some private practice. Okay, so just a brief history of diet therapy. So fasting and other dietary regimens have been in use and documented since at least 500 BC. It was first documented in the biblical times that they noticed that if you would fast people and they were having seizures, it would eventually stop the seizures. The first like modern use of starvation as a treatment for epilepsy was back in 1911 in Paris. So people would come in with having a lot of seizures. They would stop them from eating for a couple of days, and they would notice that it would start to, or their seizures would improve. Now, their American counterpart was named McFadden, and he had claimed that fasting from either 3 days to 3 weeks could alleviate and cure almost any disease. So he wasn't really being specific to epilepsy, but he really promoted fasting in general. Now, diet therapy was introduced in the 1920s, and it was designed to mimic the metabolism of fasting. And then at that point, I'm not entirely sure if I'm saying this name right, but I believe it's Galen. He was the first to document cognitive improvements when fasting. So he wasn't just addressing the fact that people were having improvements with their seizures, but he also noticed like overall cognitive benefit to diet therapy. And so the first documented as far as like the time frame with seizure improvement was from two researchers at Harvard, Cobb and Lennox, and they were the ones who had noticed that seizure improvement would typically occur after 2 to 3 days of diet therapy or fasting. So back in 1921, that's when they noted that the ketone bodies which we're looking to achieve in diet therapy were produced by both starvation or a diet that was very low in carbohydrates and high in fat. So at that point, they realized that the metabolism was the same in those two states, either fasting or going on a specific diet. and it was proposed to trial a ketogenic diet in the patients with epilepsy. And it was found that this was as effective as fasting, but it could be maintained for longer periods. I mean, obviously, we cannot fast people for like weeks and weeks on end. Like that's just not going to be good for anybody's health. But if you're on a ketogenic diet, or one of the different diet therapies for epilepsy, you could maintain that for several years if you wanted to. The initial diet calculations were very similar to the ones that we use today. And unfortunately, while the diet was very successful for seizure control, once they started discovering the anti-epileptic drugs, the diet was kind of not abandoned per se, but it fell by the wayside. People were really excited about the anti-epileptic drugs. They thought that that was going to be kind of like the way of the future to cure all the seizures. So it became very difficult to find people that were trained in the diet therapy. So since the diet became less popular, dietitians didn't really know how to manage the diet. And so because they weren't doing it properly, people didn't think it was effective. So it kind of really like fell out of favor for quite some time. Now, back in the early 90s, there was a Dateline episode about the ketogenic diet therapy. And one of the patients who ended up seeking treatment for keto diet therapy was named Charlie Abrahams. And his father was I believe he was either a movie director or producer. And after Charlie Abrahams was treated by the ketogenic diet therapy, I mean, he was completely seizure free. His family founded the Charlie Foundation. His father made a movie about his case. And after that, it really started to kind of pick up speed again. The first epilepsy diet treatment book was published. Back in 2003, the modified Atkins diet was developed. And since then, they've developed international consensus guideline. And they've also developed specific adult guidelines. And back in 2021, the diet actually marked its 100th anniversary of use. Okay, so who uses diet therapy? So typically, if we're looking at a patient for diet therapy, it is somebody who has failed the traditional drugs, or if they're very poor candidates for epilepsy surgery. So sometimes we'll look for somebody who has failed 2 or more appropriately chosen medications. Sometimes we don't necessarily wait until they fail 2 or more. Some people want to try more medications before going to diet therapy. So these are just kind of like general guidelines. It's not like a hard and fast rule that you need to fail 2 drugs before trying diet therapy. If we are looking for someone to go on diet therapy, they would be someone who is compliant with drug regimens, because you do need to be compliant with dietary therapy if you are going to initiate it. We do complete screening labs just to rule out any thing that might be a contraindication to the diet. Some people might start on the diet initially if they don't want to pursue drug therapy, or if people feel that they don't like the side effects of medications. Some people find that they have like personality or cognitive changes, and even though if they might be having some seizure control, they don't like the effects of the medications. The diet can be used by all ages. There's definitely way more research about the diet in children, but it is absolutely appropriate to use for adults too. It can be a little cost prohibitive and time consuming. It does require a little bit more prep work for most cases. We always assess for any psychosocial barriers, like do you have good family support? Are you preparing your own meals? Like we look for lifestyle things that might be an issue, just to make sure that if we're starting somebody on diet therapy, that we are going to set them up to be as successful as they can be. Some people might need to be on diet for 2 to 3 months prior to noticing improvement. And sometimes that's just because we have to kind of tweak things a little bit to really achieve what our goals are going to be. And then the typical duration of therapy is usually 2 years if somebody's doing well on diet. And at that point, we may not see further benefit as far as continuing. Okay, so this slide does apply for children because we don't have like a research slide like this for adults, but these are the syndromes and conditions for which the ketogenic diet has been consistently reported as being more beneficial. And I will say, as far as the ones that are starred, the GLUT1 deficiency syndrome and pyruvate dehydrogenase deficiency, those are considered, those are 2 disorders where diet therapy is considered like the first line of defense, and it should be initiated if somebody has one of those diagnoses. As far as contraindications to the use of the ketogenic diet, most of the things that we would consider an absolute contraindication are going to be disorders that are going to present in childhood. So we don't really need to worry about those so much with adult patients. And then we have some relative contraindications like osteopenia or osteoporosis, because diet therapy can contribute to some issues with bone density down the road. If somebody has nephrolithiasis or a history of, which are kidney stones, hyperlipidemia, cardiovascular disease, cachexia, which is going to be like a state of like almost like like a disease-based anorexia, and like muscle wasting. Pregnancy, we wouldn't start diet in, although some centers have had adult patients who were on diet therapy and got pregnant and maintained the diet through their pregnancy. But if somebody is pregnant, we would not start diet therapy while they're pregnant. If somebody has a carnitine deficiency, and then acute pancreatitis because the pancreas is required for fat metabolism. So as far as looking at nutritional needs, there's no calorie restriction. We do use our clinical judgment to estimate needs. It's usually based on current intake. So we often will ask people to have like a food diary or a food log. Sometimes patients will kind of keep it in an app. It's just easier that way. And then we can review it and kind of assess how much we think that they would need like moving forward. Goals for our adult patients are to maintain or achieve a healthy weight. And for comparison, as with the pediatric patients, we're looking to meet calories for growth. So it's a very different when we're looking at those two groups. We provide the dietary reference intake for protein unless there's increased needs for some reason. And we do always make sure that the person is going to meet 100% of their fluid needs, which is especially important in prevention of the kidney stones on the diet, which can happen. As far as diet initiation, so just so everyone's aware, screening labs do need to be completed prior to initiation of diet therapy. I do not advise anyone to start diet therapy on their own unless they're under the care of a physician with a dietitian. There's some extra monitoring that needs to be done. So it's really important that you're working with someone who knows how to handle the diet. Um, all the preparation and training must be personalized for greatest likelihood of success. I've had some families work with me for maybe like a month or so before they felt confident prior to moving forward on the diet. I mean, I've also had some people who are like, let me run through this with you. We do our diet education, and then they're like ready to go as soon as their labs get back. So everyone's very different, but really, in order to be successful, you should have like personalized guidance. Diet initiation is usually done in an outpatient setting, and it can be rapid or gradual depending on the clinic or your individual wishes. So like I said before, some people need more prep time. They want to get more comfortable. They want to spend some time like experimenting with recipes. And then you have other people who are just kind of like, okay, this is my new diet. Let me go. Um, Anytime you are starting diet, you should notify any other care providers who might prescribe medications. And some people want to start with like the most liberal version of the diet and then go to more strict diets. Some people kind of want to go with a very strict version of it. But typically, if we're going to go with diet therapy, we always ask people to commit for 2 to 3 months before we can really assess if they're having a response to it. And then if it's not working at that point, then we can say, all right, let's wean off. So the different types of diet therapy are pretty much the same as we would be utilizing in children. There definitely are some differences as far as like the diets that we would recommend for adults versus kids, but the ones that we can work with are the modified Atkins diet, the classical ketogenic diet, the modified ketogenic diet, the low glycemic index treatment, and the medium chain triglyceride oil diet. So just some notes, the MCT oil can be used to supplement all forms of the ketogenic diet, even if you're not doing an MCT oil diet. There's no clinical trials that directly kind of compare the different diet therapies with one another in adults. There are more studies in the, again, pediatric population. And there are a lot of people who are interested in ketogenic diet therapy for other neurological conditions, but we definitely need more evidence before we can start recommending it as kind of like part of the treatment plan. However, I will say I have had people with like brain tumors and some other neuro issues who really just wanted to pursue diet therapy, and I was happy to work with them too, under, of course, the care of, or the blessing of, their physician as well. So as far as the classical ketogenic diet, this is going to be high fat, adequate protein, and very low carbohydrates. So what we're doing is we're switching your body's primary fuel source. Currently, on a day-to-day basis, everyone is using glucose or carbohydrates for energy. And in this diet, what we're looking to do is to shift your metabolism to using fat for energy. This works on the mitochondrial level, and this is going to be mimicking the metabolic state of fasting. And our goal is to achieve ketone bodies, and this is going to show up in both the blood and the urine. And for some reason, when your brain is using these ketone bodies as fuel, it helps with seizure control. We're not entirely sure why it controls your seizures, but it can. So the classic ketogenic diet is calculated at a very, very specific ratio. So when we say ratio, we say that means the total grams of fat to the grams of carbohydrates plus protein. So a ketogenic diet ratio at 4 to 1 is going to be 90% fat, 8% protein, and 2% carbohydrate. And we really try to keep the carbohydrate as low as possible because you do have protein needs that you have to meet. So that's why the carbohydrate is negligible in this type of diet to allow enough protein for your your daily needs. So there's a 40 to 50% chance of having at least a 50% seizure reduction. And I'm sorry, I realized I wrote may twice in the last line, but there may also be improved alertness, mental clarity, and social interaction. So in this diet, this is a very difficult diet to do if you're eating by mouth. I really would not do the classical ketogenic diet in most adults. It's very, very strict. Every gram of food that you are eating has to be weighed out on a gram scale, and then the entire meal has to be consumed. And it really should be consumed in like a relatively not you don't have to like speed eat, but you really should consume the meal within like a half hour to an hour. You can't be dragging it out and kind of like picking on it or grazing at it. In this case, if somebody wanted to do the classic ketogenic diet as an adult, we would give them access to something called a keto diet calculator. And what that is it is a website, and the woman, her name is Beth. She's an amazing keto dietitian. She has built this calculator, and you kind of enter your foods in there, and it calculates all the ratios out for you so that you don't have to do the math by hand. So we would give you access to the calculator if you wanted to pursue this type of diet, but it is very difficult, and it doesn't work with a lot of lifestyles. You can't really go out to eat. You cannot, if you're going out, you have to kind of bring your own food with you. If you're traveling, it makes it very, very difficult. And when we're looking at it, the higher the ratio, the lower the amount of protein and carbohydrates. So we would typically start at like a 2 to 1 ratio and advance as appropriate, depending on blood work and how people are responding to it. But again, this is very, very strict. So I would probably only do this if somebody had like a feeding tube, or if they had such poorly controlled seizures that this was kind of like a last option for an adult. We also have something called the modified ketogenic diet. This is kind of like a hybrid between the classic ketogenic diet and the modified Atkins diet. So again, we are also calculating out the energy and protein needs. There's a little bit more carbohydrates in this one. It's about 5% of the energy intake. So that comes to 20 to 30 grams per day of net carbohydrates. So total carbohydrates minus the fiber content of the food is your total net carbohydrates. Fat is going to be making up about 75% of the diet. All carbohydrate, again, intake is weighed and measured, and the fat intake is more portion guided, but we're not weighing it out like we would in the classic ketogenic diet. There is moderate protein intake. It's not unrestricted because you don't want to be consuming excessive protein intake, because if you're on diet therapy and you're eating very, very large amounts of protein, sometimes your body can change once the protein's broken down into amino acid, your body can change 2 of the amino acids into glucose if it wanted to. It's called gluconeogenesis. So we wouldn't want someone to be having a very, very like excessive protein intake on this type of diet. So the modified Atkins diet is definitely more liberal, but will still achieve ketosis if it's done correctly. So this is to try to get or produce ketones in the simplest manner possible. We are only focusing on the carbohydrate restriction. So the carbohydrates are restricted to 20 grams per day of the net carbs. So again, that's the total carbs minus the fiber content. So we do space out the carbohydrates throughout the day. You can't bank them for one meal. I know there's like a lot of diet plans out there, like I like Weight Watchers, and some people will like bank their points for like special meals or events. You really can't do that with this diet. They would need to be spaced out throughout the day. So we're only measuring, again, the carbohydrates. We don't restrict the protein, and fats are just added to all meals and are encouraged to satiety. And this is the most common diet utilized for adults with epilepsy. It is significantly more easy to manage than the classic or modified ketogenic diet. Most restaurants or schools can accommodate. If you're like on the run, people can grab things in like a 7-Eleven or a Quick Check. Like it's easy to, not easier, but it's you can kind of function a little bit more out in like society as far as like maintaining as much of your normal lifestyle as you can without having to bring your own food places. So this is probably what I put most adults on to date. We also have the medium chain triglyceride oil diet. So in this diet, it is we're also calculating out the total energy and protein needs. But the way this diet works is that most of the fat is being provided as an MCT oil or an MCT oil emulsion. And MCT oil is a little bit, or medium chain triglycerides are absorbed a little bit differently by the body. So it promotes ketosis and you don't need to consume as much fat. So 15% of the energy provided is going to be protein, 15% is going to be carbohydrates, and foods are weighed and measured here, but some people prefer to do this type of diet since it's a little bit more, you can have a little bit more protein and carbohydrates than the other ones. Something to note is that if you are using MCT oil, you do want to make sure to introduce it slowly because it can cause gastrointestinal distress. So we've seen some people where they try to add, like a tablespoon or so. We usually recommend trying to initiate MCT oil or introduce MCT oil at like 5 to 10 milliliters at a time, just so you can get used to it and adapt to it before you increase it. The other diet that we would utilize for adults is called the low glycemic index treatment. So we do calculate the total energy and protein needs. The carbohydrates probably provide around 10% of the total energy. So it's about 50 to 60 total carbohydrates per day. We're not subtracting the net carbs here. Protein is about 30% of the calories, and then the rest of the diet is fat. So while this definitely allows more carbohydrates, it's restricted to those with a low glycemic index. So that would be something with a glycemic index of 50 or below. I find this diet to be a little bit tricky personally because there's really no obvious way to tell if a carbohydrate food is a high glycemic index food or not. I mean, if you're like out at a restaurant, you see a piece of bread, you know that that contains carbohydrates. So if you're doing modified Atkins, you wouldn't eat it. But if you're, offered like quinoa versus barley, like you can't just look at a food and know which one has a higher glycemic index or not. So I've had a few adult patients on this diet, and I usually just have them download an app. And until they get familiar with the carbohydrate foods that are low GI, they will usually just kind of look it up. On a day-to-day basis until they're like really comfortable with what foods they can safely consume. All right, so when we're looking at medications should either be in a tablet form or keto-friendly liquid that's made by a compounding pharmacy. Usually for adults that we would just get it in a tablet, but sometimes people prefer liquids or if they can't swallow pills. So any traditional liquid medication, and that includes things like cough syrup, like some of the allergy syrups, like any flavored chewables and gummies are all going to contain extra carbs. So if you are pursuing diet therapy, you need to make sure that you are switching all your meds over and that nothing is going to be something that's potentially dangerous. Any of the medications can be checked in the keto diet calculator, which we can get, again, if you are starting diet therapy, your dietitian can give you access to that. Or the pharmacists do have like their special booklets which have like the carbohydrate contents of meds if we don't have that readily available. Just something to note is any anti-seizure medication adjustments really cannot occur at the same time as diet initiation. It has to be at least 3 to 4 weeks before or after if possible, just because if we see like, oh, is there a change in seizures? Is there a change in neurological function? We don't really know what's causing that if we're changing everything at the same time. Um, the goal for a lot of people is that they want to reduce their medication dosage. And, that some people can get to that point where if they're doing really well on the diet, their seizures are well controlled, we can, obviously the physician can start to kind of maybe taper down on some of the meds. Or I've had a few patients who were able to come off of some of their medications. But again, that's going to be very individual depending on response to diet. But again, all healthcare providers and your pharmacy just need to be aware of diet therapy in case there's any new prescriptions that need to be checked. Supplementation, the majority of the recommendations lean towards starting a multivitamin and mineral supplement when initiating diet therapy, just because these diets are so limiting. You want to make sure that you're kind of covering for any deficiencies that could potentially develop. Some adults may need additional calcium and vitamin D. Magnesium is usually only recommended if there's a deficiency present, and we don't typically recommend carnitine in adults unless the levels are low or if an adult is becoming asymptomatic, whereas we would use it a lot more frequently with children. Some people might need to eat salt, add salt to their food, and this is really because since a lot of the foods that you're eating are going to be like meats and vegetables, and you're not able to have processed foods, some people aren't going to be eating enough sodium at that point. So that's something that may potentially become an issue. And then again, we really need to make sure that anybody on diet therapy is consuming adequate fluids just to prevent any of the, constipation or to help prevent kidney stones as well. So monitoring while we're on diet therapy, we are going to be monitoring like neurological status, so seizures or any other pertinent symptoms. Like, for example, if somebody's having auras, we'll keep track of that. We're going to be monitoring for ketosis, which is monitored via the blood or the urine. I have the blood goals, which are 3 to 5 millimoles per liter, or moderate to large urine ketones. So if we're starting somebody on diet therapy, we typically have them check their urine daily until ketosis is achieved, and then after that, we can decrease the frequency of testing. Some of my adult patients may only test once a week, and as long as they're making their ketones, then it's okay, fine. We don't really need for them to be checking more. Some people will also need to be checking their glucose. This is not something I usually recommend unless there's a concern for hypoglycemia. But because of the nature of the diet, people can have lower blood sugars without necessarily being symptomatic. And really, a blood sugar as low as 60 can be okay on the diet. As long as you're not having symptoms. Typically, we would do blood work every 3 months unless there's a concern that we need to keep like a closer eye of. And we would ask them to keep an eye on their food intake. Some people might need to track all their macronutrients versus just tracking carbohydrates. We'll usually ask adults to weigh weekly. And we would also, depending on people's bowel habits, we might be keeping an eye on their fluid intake and their regularity just to make sure that we're not having any issues with constipation. So some things to note when we are starting diet therapy, some people will experience something called like a keto flu. So there's increased fatigue, some thirst, hunger, some irritability. I've been told by patients that they normally will, I'd say maybe like between 3 to 5 days, they would experience this. And then after that, they start to kind of get out of it. The most common side effect of diet therapy is going to be altered bowel habits. Because these diets are going to be so restrictive, you're going to have a significantly less fiber intake, which can lead to constipation. And also, if you're not drinking enough, then that can exacerbate the constipation. So in some cases, we will add a fiber supplement. But the other thing to note with the fiber supplement is you really have to make sure you're including enough fluid with the fiber supplement, because otherwise, if you're taking a fiber supplement and not taking enough fluid, that can increase your constipation. So some people will just end up requiring something like a Miralax or a glycerin suppository, but if we can work through it without having to resort to drugs, we will try to do what we can. But again, we can't have somebody who's not having bowel movements for like days on end, so we may have to resort to a medication. There is something that people can develop called acidosis, which is an increased level of acid in the blood. This would be more common on like the very strict versions of the diet, and it would show up in the blood testing if we ran a BMP on somebody. So that's the basic metabolic panel. We don't necessarily need to treat this with a medication per se, but we can correct this with like a baking soda. So that would need to be dosed by MD or a dietitian, and it's not advised to just take it prophylactically unless we notice that you are starting to produce some acid in your blood. There is an increased risk of kidney stones due to acidic urine, and you're at greater risk if you're having inadequate fluid intake. And then as far as hypoglycemia, like I said before, blood sugar can go as low as 60 while in diet therapy, and we're only treating it if somebody has a blood sugar below 60 or if they're symptomatic. So as far as discontinuing or stopping diet therapy is very similar to a medication, whereas you need to wean the diet. It's like you would wean a medication. So you cannot just randomly stop it. If you randomly stop diet therapy and you are in ketosis and you have a history of seizures, you run the risk of developing status epilepticus due to the rapid influx of glucose into the brain. So it's very important that if you want to stop diet therapy, you are doing so under the direction of your doctor and dietitian. And this is something where you really you can't have cheat days. So it's just something to be aware of, that if you are doing diet therapy, you are committing to it. The length of time required for weaning is going to be depending on how long somebody's been on the diet. So if somebody's been on the diet for, like 2 or 3 years, it's going to take a lot longer to wean them off the diet than if they were, let's say somebody tried the diet for 6 weeks, they decide it's really not working for them. We can get them off the diet a lot quicker. A weaning protocol is going to be individualized depending on the type of diet as well. And you would be given specific weaning instructions by a dietitian. So I usually will meet with the family or the patient prior to weaning the diet. And I will, we'll kind of talk through a plan, and then I will type out like written instructions and then send that home to them. Just to make sure that everybody's on the same page and so that we can make sure that we're weaning safely. And then as far as like, is this effective for adults? So the research that I've read, it shows that it'll reduce seizures in nearly 60% of adults, but it can also improve quality of life and reduce some other neurological symptoms. Like I had mentioned earlier, can provide some more mental clarity. The major limitation of the diet is going to be adherence. It's difficult to stick to this type of diet for a very long period of time. Compliance for the modified Atkins is going to be higher than like the classic or modified ketogenic diet, but still it's really only close to the 50% range. The risks of the long-term side effects of diet therapy are still, again, largely unknown. I mean, this diet was really only popular again starting in the 90s. So I don't know if how long the longest patient has been on diet therapy, but we don't really know if somebody's on this for years and years, exactly what could potentially happen down the road. There is greater adherence and success in those with feeding tubes just because it's a little bit easier to control. And the major barriers here are really going to be difficulty with the carbohydrate restriction. And some people feel like if they're not having the response that they want to treatment, then they kind of lose interest in maintaining the diet therapy. And then I will happily take any questions that anybody has at this point.
Hi there. Yes, can you discuss strategies for dealing with food cravings and especially combating the psychological need to give in? Is this a sign of addiction to certain foods or certain associations with certain foods?
Okay, this is a great question because I've had this happen more than one time. I cannot say for certain that it is a sign of addiction per se, but the way a lot of foods do produce like chemicals in your brain that make you would want them more. So it is very difficult to kind of like stop them completely. I will say that people have told me once you're on diet therapy for a couple weeks, the cravings just kind of go away because you're not exposed to them, so you don't want them as much. If the cravings would become an issue, I would probably tell someone that they would have to wean onto the diet slowly, because if somebody goes into diet therapy and then they're having cravings and then they're giving in, they could potentially end up in a dangerous situation. So if somebody was very concerned about the fact that they may have cravings that they're not able to like stop, or like stop themselves from eating something, I wean on slowly, like maybe cut down to, I don't know, like 100 grams of carbohydrates per day. And then it would be very dependent on the person how we would kind of work through this. But we would try to put them in a situation that they're going to be as safe as possible if they're going to be maintaining diet therapy.
Okay. Do you have to stay on this diet for life to get seizure control?
No, definitely not. There are they the duration of therapy that's typically recommended is 2 years. After that, it doesn't show any further benefit in really continuing diet therapy. I do have two patients. They're both adults now, but they started when they were children, that have been on the diet for about over 10 years at this point, and it's mainly um I think at this point it's there's just a lot of other things going on that they just don't want to wean the diet. But after really about 2 years, we would suggest if you're ready to wean at that point, we can start weaning.
Are there specific lifestyle changes that individuals have that they should consider if they're going with this diet plan, a nutrition plan, like, sleep and stress and all that, physical activity?
Um, Definitely sleep and stress. I mean, any physical activity is interesting with the diet, because depending on how active you are, you may be able to have a little bit extra carbohydrates. But um so I haven't had any patients that have been like extreme athletes, like marathoners or anything like that. If I had somebody who was interested in doing some kind of like more aggressive activity, I would probably reach out to somebody at one of the major keto centers, just because I haven't dealt with anything of that nature. Like I've had kids who like did sports in school and they were able to have a little bit more carbohydrates, and I've had adults who would like go to the gym regularly, and you might be able to get a little bit more carbs in there, because you're burning so much more through the physical activity. But as far as that would be, again, very dependent on what type of exercise you're doing. But as far as sleep and stress, absolutely can help with seizure control as well. I do find a lot of patients have more seizures when they're tired. And then stress can also, for some people, impact their seizure control. So those are absolutely things that should be worked on at the same time as diet therapy if you really want to get the best response. I mean, we only have so much control over them. Like a lot of people have very stressful jobs, and we can't really control, our external stressors sometimes. But if whatever you can control in those aspects would be beneficial.
Can you share any success stories of adults with epilepsy who've experienced positive outcomes through the dietary interventions?
Yeah, I mean, I can't obviously discuss patient very specific patient stories, but I have had a number of adults who, I believe I had one adult who was completely seizure free, and she was also trying to lose weight, and she lost weight, and it was very exciting for her, because I hadn't heard from her for like 2 months, and then she emails me and told me that she had lost all this weight. So it was that was a very like exciting email to get. But I would say for my other adult patients, it's kind of I've had patients who are successful, have reduced seizures, have reduced auras. Um, but it's kind of dependent on how compliant they are. So like I had said in the PowerPoint, that tends to be a limiting factor for a lot of adults, is that sticking with the diet can be difficult. But the ones I have had who have been compliant with the diet do have done well with it.
So if you collaborate with other healthcare professionals, so if someone came to you and wanted for you to set up a diet for them, you need to work with the neurologist, probably in your practice. Is that how it works?
Yeah, I work so usually the neurologist will refer the patient to me directly. But I get my referral. I go through the diet with the patient, and then I will either work with the doctor or the nurse practitioner, depending on their availability, to talk about the meds, talk about strategies. Do we think this is a good candidate? So I never make the decision on my own to start someone on diet therapy. And I do need that. I cannot prescribe labs and things like that, so they will be the ones ordering or filling out those prescriptions. So I do work very closely with the physicians and like the nurse practitioners. And I mean, like, it's really a team effort when we're starting someone on diet therapy. So even like as far as like the medical assistants and the secretaries, like everyone's very involved in like kind of helping get everybody started. It requires a lot of phone calls usually.
A lot of collaboration, it
Yes,
sounds
for
like.
sure.
Is there any specific resources or educational material you recommend for individuals with epilepsy who want to learn more about nutrition?
As far as for diet therapy, the Charlie Foundation is by far the best website. They have like tons of great educational materials. They have links to different books you could buy. They also have recipes, and the great thing about the Charlie Foundation is that their recipes are designed by a chef who, I believe, she works out of a children's hospital in, I want to say, St. Louis. She has like an epilepsy test kitchen, so all of her recipes are tested with epilepsy patients. So that they're like approved and they actually taste really good. So I always recommend starting with the Charlie Foundation, or there is a UK version which is very similar. It's called Matthew's Friends, which is another great resource. I will just note that Matthew's Friends, everything is in the metric system. So if you're not familiar with that, just don't be alarmed.
I lost my screen for the question, but you talked about being on the diet for 2 years and then going off. So what if the person goes off it and then their seizures start up again?
So if somebody has been on the diet for over 2 years, the weaning process would probably be very, very slow, like a couple of months. If we started to wean them off and their seizures started again, then we could resume diet therapy and make and until we can kind of see, like, do we need meds adjusted, or do we need to just stay on the diet longer? My patients who have been on it for a long period of time, who've started to wean, have done okay. Um, I don't think any of them had increased seizures after weaning the diet, but I've only had a couple of people who have been on it for that long who have weaned off, so I don't have a great sample size personally to discuss. But I mean, if sometimes we can have people start to wean, and it's like, let's say we can wean a little bit, like maybe they're on modified Atkins, we can get to 40 grams of carbs, but if we go above that, then they'll start to see some like seizures or negative like neurological symptoms that they don't like. Then we can kind of stick with a slightly more liberalized version, so you're not on as strict of a diet, but you're still as best controlled as you can be.
You had mentioned some apps that you tell patients about. Can you elaborate more on that?
Okay, so I will usually use if somebody is tracking their carbs, I like the Calorie King app personally. And then there is another app, if somebody's on the low glycemic index diet, it's called I believe it's called MyGI. Sorry, let me just pull up my phone and make sure I'm not making up that name. Okay, so oh yeah, sorry, it's called the glycemic index. It says glycemic index load net carbs, and it's technically designed for diabetes, but it has the glycemic index of the foods that you can look up the glycemic index of the foods. So I find it to be very user friendly. I just kind of stick with like the easiest app possible, and I found those to be very easy to use.
Okay. Well, I think you've answered everyone's questions. Um, so really appreciate all this information. I will be emailing everyone that was participating, that came tonight to listen, and I'll send you Nicole's information to get in contact. Someone just asked, what's the name of the ketogenic app? Did you said Calorie King, right?
Oh yeah, so there's no specific app for the ketogenic diet, like for a medical ketogenic diet. If somebody's on like the classical ketogenic diet, we would give them a login to a website, which is called, oh my God, the keto, sorry, I like completely lost my train of thought there. It was called the keto diet calculator. So, those like a general person cannot just log into the website. You would need like a license for your clinic for it. And then like if I was seeing a patient, they're starting on the classic ketogenic diet, I would give them like a patient login, and it's kind of set with their like goals, like their nutrition plan is plugged into it. And then they can, play around with their meals, and it'll compare it. Like if somebody is going to be on like a 3-to-1 ratio, they plug in their grams of food and it'll tell them what the ratio would calculate out to be. So that's not something that is in an app form. I would love if it was, but that's not in an app yet. So if it would be, I do Calorie King for just for tracking net carbs, because it's pretty comprehensive as far as different foods.
Okay. Well, again, thank you so much, Nicole. This was very informative. As I said, this has been recorded and then we'll be posting it to our YouTube channel. So if you want to share that with information with anyone, I will be emailing everyone tomorrow or the next day with some links. So thank you again
Oh,
for
you're welcome.
wonderful
I love
talk.
doing this stuff. So anytime, you just let me know.
All right. Thank you so much.
All right,
Everyone
thank
have a
you. Have a
great
great
night.
night.
All right.